Hello, everybody. Welcome to another edition of the AFR EMS Case Studies. My name is Chris Ortiz. I'm the EMS Division Chief for Albuquerque Fire, and today we are joined by the Medical Director, Dr. Kim Pruitt.
Hi, Chief.
And then we're joined by the Captain, Jason Hackett.
Hi, Chief.
Appreciate you, sir. Thank you for coming out to talk with us today.
Thanks for having me.
So, normal assignment, ALS Engine 2.
Yes.
This was a post-procedure hemorrhage that you all responded to, and Engine 2 and Rescue 2 were responded actually to a 9 Echo call.
Correct.
Is how the initial call came in at a gynecological office for a 35-year-old female. A lot going on there. Tell us just from your perspective and your experience, some of the things that still run through your head when you're en route to a call with that information.
Well, there's definitely a lot of things that we're trying to think about because we just don't run these calls very often. So, we're worried about the mom, if this is a viable fetus, are we going to have two patients? We have to think about all these things prior to going. Plus, we have a cardiac arrest. So, if we have to, call the consortium doctors to come out and help. I didn't know where this was going, honestly. So it's concerning and it's rare. And we were able to put out a good effort for this. So it was a very interesting call.
Thank you. So now you guys arrived on scene. It sounds like you're greeted by medical staff, obviously, from the clinic. What information were they able to divulge about the patient and what was going on?
So this clinic is a clinic in Station 2. They do quite a few of the abortion DNCs. And so we had actually gone there earlier that day for probably about an hour prior for another similar call, not as sick of a patient. So when we arrived, we knew where we were going. We walked in. There were multiple people inside of a room and a patient that was sitting in stirrups. Who was looking as white as this piece of paper right here, and she was actively bleeding, and there's probably 10 or 15 providers inside of the room. And so when I looked at her, I was obviously very concerned upon initial impression, and seeing the blood on the floor, the doctor that was in the room stated that they did a DNC for a miscarriage, and when they did that, she started to bleed. And when she was bleeding, the amount of blood was at least 2 liters of blood that she had lost. So they had put a uterine balloon in, and they had packed the vagina, and she was still actively bleeding. So initially, her vital signs, so she had a heart rate of 152, and she had a blood pressure of 102/71, and she was satting 99% with a respiratory rate of 24. That was initially. So I was really concerned about that heart rate of 152. I feel like we're starting to go into a shock. So we did a second reevaluation of blood pressure prior to leaving, and that's when we got systolic of 88. With a heart rate of 150. So it was very concerning for us just looking at her condition and the amount of blood loss that she's had to this point.
Absolutely. 2 liters, and then with those vital signs, it's pretty indicative of a sick patient. Not a 9 Echo, but did they say they had lost pulses prior to your arrival?
Yeah, so that was so they initially had done CPR, maybe less than a minute worth of CPR, and the patient started coming around. It's possible that the patient have lost pulses, but I'm not quite sure if it was that or maybe just a syncopal episode because of the amount of blood loss she had. So we did not do CPR. We did not work it as a cardiac arrest. She was alert and oriented and talking to us while we were doing our assessment on her. But she was stating that, she was very concerned. She says, I'm starting to feel sleepy. She says, I'm worried about my kids. I want to live. All these very concerning terms that, always pique our intuition. So,
Doc, I'll kick it over to you on the risks associated with these procedures. How risky are they, and what are things that we should be looking for when we interact with the clinics?
Typically, they're not super risky, but when they are risky, they're very risky. So in general, I think the poor outcomes are a very low percentage, but when they happen, they're incredibly severe and pretty scary. They do a pretty good job. The biggest complication, obviously, is bleeding. In a pregnant uterus, there's obviously a lot of extravascular blood flow. To the area, and the uterus becomes kind of soft, so it's either easy to perforate or hard to attain hemorrhage control. And in this particular case, this patient, she knew she was going through a miscarriage about a week earlier. And there was an incomplete passage of the tissue from the miscarriage, so it was an incomplete miscarriage. And when that happens, for the mom's safety at that point, they need to go in and clean out the uterus so they can contract down to stop the risk of bleeding and come back to a normal size. Otherwise, there's risk for infection or other problems.
So we had the balloon was in place, the uterine balloon. They had done some packing. And talk to us about what your all's next steps were in terms of treatment and care.
Well, so, my idea is we need to get some fluids on board. So they had an IV established. They were running saline, and they had a pump on that. So we were trying to get the fluids in as fast as we possibly could. Trying to stop the hemorrhage was obviously a big concern for us, but it's very difficult for us in this situation to do so. I feel like the OB doctors were doing every procedure that they possibly could by initiating TXA and putting in that uterine balloon to try to stop the bleeding, but it just was not working for us. So the next step for us was rapid transport to the hospital. Recognition also. I mean, noticing that this patient is going into shock and decompensated shock, and now we need to get her to a place where she can get that definitive care and stop that bleed.
Definitely.
So.
And for EMS purposes, Doc, like in this situation, what are some of the things we can take note of that the facility can help us with guiding our treatment and information to give to the docs?
Very important question. So you have the privilege in this case, I guess, or the benefit of being in a clinic with providers that have handled these types of hemorrhages before, and they are typically fairly prepared to handle them. So they had packed the uterus, which wasn't necessarily effective, but was the right first move. It's essentially just doing direct pressure, just like we do on most bleeding. And they had given her several medications. So TXA is a medication that, especially in hemorrhagic shock, has been proven to help facilitate the clotting cascade and maybe have better outcomes. So they had given her that. And then, as well as two other medications to listen for in these early trimester DNCs, is Methergin, which is essentially a smooth muscle constrictor. So those small vessels that are feeding the uterus, it's just like, kind of think of it as a pressor for the uterus to help clamp down those vessels, in addition to misoprostol, which is a medication that's actually administered rectally. And one of the important side effects to know about this, it also helps control bleeding and change the vasculature in that uterus, but can also cause unintentional diarrhea as a side effect. But it's basically they're throwing the whole kitchen sink at her, trying to get her stabilized to where, at this point, when the hemorrhage is this bad, usually it leads to a hysterectomy. Because if you can't get it under control with those 4 interventions, it's at that point it's a life threat, and she needs to go to an operating room where they can do the hysterectomy.
And we've talked about like Pitocin and oxytocin. Talk to us a little bit about that and what we should look for.
Excellent question. And I know Jason had brought this up when we talked about it earlier. I think probably one of the drugs, as we mentioned, these that we're more familiar with in childbirth would be Pitocin, or oxytocin is another name for it. It's a standard of care when children are born to give to the mother to help prevent a postpartum hemorrhage. The interesting thing about this, that they didn't give it in this case, is because it's too early in the pregnancy. Those receptors in the uterus and then the female body are not present until after the 20th week of gestation, and so it's not a medication that they'll give for hemorrhage control in those first 2 trimesters. It just wouldn't be effective.
Understood. All right. Fast forward back to the scene. We talked about, you identified really it was just fluid replacement. It's going to be rapid transport to the hospital. I know we rode in with Albuquerque Ambulance, code 3 to UNMH. Any changes in route, anything we did differently, or how did that go during the transport?
Patient continued to decompensate, and then once the patient was still alert and oriented, but still showing signs of decompensated shock with the blood pressure and the heart rate. Thinking back on it, what are the other tools that we could use to try to help with this? They always teach us in paramedic school of maybe a fundal massage might be helpful. And that was something we didn't do, which I think maybe might have helped that's maybe at some level. But yeah, it was a sad situation, and it wasn't getting any better with our interventions. She needed to have bright lights and cold steel.
And was there still active bleeding with all those interventions during transport, or had it
Yes.
stopped or been contained?
No,
Still bleeding?
it was active bleeding. Yeah, it was bleeding onto the gurney and down onto the floor. So it was a significant amount of blood.
And they don't have blood on site there. Were they able to transfuse her there? Or?
No, they had no blood.
That was one of my backup questions.
Oh,
too,
sorry,
just out of
Chief.
curiosity. No, I was just wondering as well if they did have blood, just because it's probably pretty prevalent that those situations could happen. But it's interesting to note.
Would have been nice if we had blood.
It will be nice
But,
when we get blood.
We're working there. Okay.
Yeah.
So in talking about blood, sounds like she arrived at the ED. The crew did a great job of getting her there quickly. She get the transfusion, I assume, at the ED.
Absolutely, yes. With those signs and symptoms of shock, that's when she's bleeding blood. We need to replace the blood because as good as saline will do to fill the tank, it doesn't carry those oxygen molecules like the red blood cells do. So the transfusion to get her a little more stabilized, get the OR set up. Your report and you taking the time, even though she was critically ill, to get all the interventions that had already been done really pays dividends when you show up in the ER, because we're running through in our mind, did she get this? Did she get this? Did she get this? Trying to think of other things to do. And the fact that you got a really solid history and a solid turnover from those providers in a hectic situation, I think really helped facilitate her care.
I also understand that, the nurses were saying that from the time that she arrived to the ER and going back to the OR, her rhythm started to change. She started going into VTAC. And so her heart was obviously not getting enough oxygen and was showing signs of that.
And I'm a big proponent of what sounds like silly questions, but I'm going to put you on the spot, Doc, and ask what you would ask of our provider. So thankfully, the patient was no longer in arrest upon their arrival. Had she been in cardiac arrest, is this a traumatic arrest? Is this a medical arrest? How are we working it, and when are we leaving?
That's a great question. So if she arrests on your way to the hospital, I think in this situation, and this is tough and you can't really write a guideline for this, but I think the right thing to do would be to start CPR and start a pressor. And just add more of that clamping down ability, whether it's epi or whether it's Levophed or whether it's both, getting those in her, trying to sustain whatever volume she has left to perfuse her heart and her brain. And then I don't think it would fall in the category of a trauma arrest. It's not penetrating, it's not blunt, it's just bleeding. So that would be really, really tough.
Yeah. I'd probably
glad it
default
didn't
to
happen.
transport. And
Yeah, just transport it.
Yeah, because she was young also. She's only 35 years old.
Yeah.
So,
And we know
yeah.
she just needs a transfusion and then ultimately hemorrhage control. So
Good to know. Good thoughts. Cap, I'll end with you. Myriad of experience. Obviously, been doing this for a long time in this system specifically. A lot of outside experience. What pearls of wisdom would you pass on, especially being on an ALS pump or being on a big red truck, for the arrival of those first crews if they were to encounter a situation like this?
Well, these situations, we just don't see them very often. And so obviously get in your textbooks and review it prior to something like this happening. But remember, we just go back to our basics, our ABCs, our vital signs, and support those vital signs. And if there's an intervention that we could do to try to mitigate that bleeding, we try to do that. And beyond that, recognition is what I used to teach the paramedic students. If you can see that a patient is presenting that is pale and diaphoretic, blood is on the ground, we know that there's a bleed, vital signs are registering with signs of shock. That's one of the main things as a paramedic to understand is recognition, and then being able to display that recognition to the next provider. Because when we transfer that patient over to Albuquerque Ambulance, that's a brand new paramedic that's getting information from you, and if you can display that to them so that they can pass that on to the ED staff. So it's got to change hands a couple times. Make sure you get a good history, get those good base set of vital signs, and try to support them with your interventions.
And also probably a familiarization with women's health facilities that are within your response district, right? Because there's a range of services that are provided at those facilities, and not all of them are going to be treated the exact same in terms of the type of care that you're going to provide. So I think that's key to involve yourself with those stakeholders and knowing what their capabilities are. Do they have blood, right? What's the best way to access the patient? All of those things I think are key, which it sounds like you've been to this facility before, so that's helpful in getting familiarization with them.
Yeah, a couple times. We're planning to go back and do some ALS interventions with them to get them trained up to make sure that, hey, well, this is what you can do in this situation. So that's coming in the future.
Fantastic.
Yeah.
I really appreciate you taking the time to come talk about this important topic. I think this was great. This is an eye-opener for a lot of us. So thank you. That's all we have for today's case. If you have some interesting cases you'd like to bring, reach out to any of us, reach out to 78. You can use our SharePoint tab. But until then, we'll see you next time. Thanks.